Let's begin reviewing the abdominal assessment. So, take a look at your abdominal cavity. You do need to know the organs that are underneath the abdominal area. So, if your patient presents with pain, you can identify which organs may be the cause of their pain or investigate more tests or symptoms or questions that you can ask them regarding that area that they're experiencing pain in. Make sure you know the landmarks and organs. So here we have our right lower quadrant is where you will always begin your exam on the abdominal part of the exam. And then you're going to move up to the right upper quadrant and then to the left upper quadrant and left lower quadrant. You need to identify what organs are in each quadrant and then in the regions that other organs are in. So if we see here, the midline, mid part is the umbilicus. That's going to be like our main focus. So that will divide your sections into quadrants at the umbilicus. In our right lower quadrant, we have our cecum and we have colon. We also have in this area an ovary for a female and the appendix. When we move up to the right upper quadrant, you're going to have your gallbladder, your liver, and your upper colon here. And in the epigastric area, which is right below the sternum, you'll notice that we have our stomach, and the stomach also goes up into the left upper quadrant as well. And then we have our pancreas and spleen in the left upper quadrant. In the left lower quadrant, we just really have the sigmoid colon, and then we have an ovary. So in left lower quadrant is more likely where you're going to have complaints of abdominal pain if it's related to constipation, because our sigmoid colon here comes around and then dumps into the rectum and anus. So here would be the most common place that you would find a mass if you're palpating for constipation. And then here it is written on a black and white sheet where you can kind of label your organs and areas and regions and quadrants. And I just also go ahead and label like testing things. So the orange is the things I might test. So I may do the Murphy test where I'm looking for, you know, gallbladder inflammation. And then Rothschild sign is actually where you press on the left quadrant and they feel referred pain in the right lower quadrant, and that's an indication of appendicitis. And then I also have the arteries labeled, so the aorta, the renal, the iliac, and femoral arteries. Then we have a suprapubic area with the bladder, and then we have ovaries in each quadrant, uterus in each quadrant, and so that is what would be labeled on your diagram. With developmental differences in the newborn, they do have a really prominent umbilicus because their umbilical cord was just removed or clamped off. So it is pretty prominent there, pretty normal to have a slight umbilical hernias as newborns as well. They have larger livers, they have weak abdominal walls, so they have a really protuberant round belly. Their bladder is a little bit higher in the abdomen. With the aging adult, we have decreased salivation and a decreased gastric acid secretion. They have delayed emptying of the esophagus, so they have a lot of reflux issues and decreased liver size, and they have a longer time to metabolize things. So if you remember from pharmacology, the older you get, the slower your liver gets, and you might not metabolize drugs and toxins as fast. With pregnancy, we have morning sickness, which can actually occur at any time during the day. It's associated with nausea and vomiting occurring between the first and second missed period. And it's also thought that this may be related to increased production of HCG hormone. Acid indigestion is thought to be caused by reflux of the esophagus, and decreased GI motility leads to increased water reabsorption, contributing to constipation. And constipation plus increased venous pressure puts them at increased risk for hemorrhoids. And a large uterus pushes the intestines up and back, and so bowel sounds can be decreased in the pregnant woman. With diet and cultural influences, the enzyme lactase is required for the digestion of carbs and dairy or milk, known as lactose. Most people have and most people have abdominal bloating and pain and flatulence, which is gas, is said to cause lactose intolerance. With obesity, some developed countries have significantly higher incidence of obesity with excess accumulation of body fat. Contributing factors include genetics, a sedentary lifestyle, high fat, high calorie diets. The US, of course, has the highest obesity rates in the world. And other contributors here would be type 2 diabetes, cardiovascular disease, joint pain, especially in the knees. Now, so lactose intolerance affects mainly whites and Hispanics population in blacks and Asian Americans. With celiac disease is an autoimmune disorder. They're not tolerant of gluten, so think about bread and wheat products. They should have a gluten-free diet. They should also be tested for this disease to ensure that they're absolutely intolerant of gluten. Common causes of constipation. So pay special attention to this slide here. Decreased physical activity, not enough water, low fiber, side effects of medications they're taking, irritable bowel disease or syndromes, bowel obstructions, hypothyroidism, and then inadequate toilet facilities. So if you can't get to the bathroom soon enough, or if you don't have a bathroom to go to, retaining the stool can make it become hard and difficult to pass. So let's take a look at this scenario here. But a nurse is performing a daily assessment on a patient who had hip surgery a few days ago. The patient reports that she has not had a bowel movement since prior to admission, and the nurse forms a hypothesis that maybe the patient is constipated. So, what subjective data should the nurse plan to obtain during the assessment to investigate the cues regarding the potential hypothesis of constipation? This is select all that apply: nausea, vomiting, lactose intolerance, and bloating. So this are the things that we would, so constipation, so that would be nausea, maybe vomiting. What objective data should the nurse plan to obtain during the assessment to investigate cues regarding the potential hypothesis of constipation? We can look at bowel sounds. We can look at um, bladder distension. So let's say the nurse discovers the following findings during the assessment, which should be reported to the provider. Should we report the patient's abdomen appears flat and symmetric? There are hypoactive bowel sounds in all quadrants. Firmness is palpated in the left lower quadrant. There is a scar from a previous appendectomy. So the answer is C. Firmness is palpated in the left lower quadrant, which is very common finding in constipation. So make sure the nurse calls the provider and reports assessment findings with the hypothesis of constipation. We got a new order for milk mag, 30 mLs PO, and the medication is given. A few hours later, the patient has a large bowel movement. So how would you write a focused soap note documenting the patient's constipation status? Your pregnant patient is experiencing constipation and asks you why. She also wants to know what she can do to manage this. So you do need to know how to teach. So what would you teach this patient to do? Well, I hope you're thinking about increase your fiber, increase your water, um, eat fiber-rich foods, get some activity in, so get some walking in, and those are the things that should help. We want to ask about changes in appetite, any changes in weight, any weight loss or weight gain. Do they have any trouble swallowing? Do they have any new onset of associated symptoms? Do they have any food intolerances? Are they taking any prescription or over-the-counter meds? Ask about pain and do a full pain assessment. Ask about, pain around eating, making it better or worse. Nausea or vomiting, when did it start? Anything that triggers it? Do they have recent travel or recent foods eaten? What are their bowel habits like? How often do they go? What color consistency is it? Do they use laxatives or stool softeners? Do they have any past GI disease, any surgeries? Do they smoke, drink alcohol? Do they do a nutritional assessment? So ask for that 24-hour diet recall to get a good idea of how they eat on a daily basis. So let's say we have a 25-year-old female patient complaining of lower abdominal pain for 6 hours. She started her menses this morning, and her vital signs are a temperature of 100.8, a heart rate of 82, respiratory rate of 18, a blood pressure of 110/70, and oxygen saturation of 96%. So, how would you proceed with an interview? Consider which systems may be involved with this female patient. Is it musculoskeletal? Is it gynecological? Is it GI? Is it GU related? We need to investigate everything that would cause abdominal pain. We can't just assume that it's menstrual cramps. So we have to do a full assessment. Ask about nausea, vomiting, associated symptoms. When was the last BM? What's her menstrual cycle like? Is this new for her? Is this something she's familiar with? What's the sexual history? Is she actively sexually active on birth control, practicing safe sex, having any vaginal discharge? Her menses. So maybe we don't want to be fooled to thinking that this could be just a GYN problem. It may just be coincidence. So we can't just ignore everything else that could be the problem. So, with further assessment, maybe this patient was very tender in the right lower quadrant and ended up with appendicitis requiring urgent surgical intervention. With additional history, when we're looking at infants and children, we want to ask about breastfeeding, bottle feeding. Are they having wet diapers? Um, how are what's their stool look like? When do we introduce new foods? New food should be introduced one at a time, to make sure we're not having food intolerances or allergies. What are the eating patterns, and if the child is overweight or not. With adolescents, have a tend to eat a lot of junk food, high fat foods. We want to ask about their dietary patterns for meals and snacks and their calorie consumption. They are at risk for eating disorders in this time frame. What is their exercise patterns like? Have they had a steady weight gain or weight loss? What kind of activities are they involved in? And about their relationships with their peers and family. With the older adults, we want to ask about their access to groceries and food preparation. What kind of foods do they eat? Do they eat meals with others or alone? Do a 24-hour diet recall? Do they have any swallowing or feeding difficulties? What are they doing at meal times? What is their bowel health like? Do they have constipation? This population is very frequently constipated. We want to educate about using high fiber. Do they use laxatives? What medications are they on? Because a lot of medications that the elderly take are, the culprits of constipation. The order of assessment in the physical exam for abdomen is very specific. Make sure you have adequate lighting. Expose the abdomen so that's fully visible. Drape the genitalia and female breasts so that it is covered. Position the patient for comfort to enhance the abdominal wall relaxation. So, the number one thing you need to do is lay your patient flat, and they can bend their knees, and that will help relax the abdominal wall and position them for comfort. Have them empty the bladder before you do all of this. If you need to, you might need to warm your stethoscope up so it's not cold and the patient won't guard their abdomen while you're doing your inspection. So after you do your visual inspection, then you're going to auscultate to use, and you might need to use distraction to keep your patient relaxed so you can get a good assessment. So after auscultation, we'll do percussion and then palpation. On inspection, we're going to look at the whole abdomen for any visible masses, hernias, anything you see on the skin. So pigment changes, jaundice, bruising, lesions, scars, striae, new moles, shiny taut skin like with ascites, any dilated veins, which would be indicative of liver cirrhosis on the abdomen, any abnormal pulsations. Now, it is normal to see pulsations from the aorta in the epigastric area, especially if they're really thin or if they have good muscle wall relaxation. But marked pulses is not okay. So if it's really, really obvious to see the pulsations, then that is something we need to investigate. We want to look at really high flow peristalsis, so visible movement of the bowels. Some visible peristalsis is okay. Reasons for abdominal distension or swelling would be obesity, so it could just be adipose tissue. Air or gas is most of the time a really huge culprit. Ascites would be fluid in the abdomen from diseases. Ovarian cyst, pregnancy, feces, so constipation, stool backup, and then even tumors. The next thing we want to auscultate is bowel and when we're auscultating, we're going to auscultate bowel and vascular sounds. We're going to do this first because we don't want to increase peristalsis by tapping or rubbing on the abdomen. So we want to hear it at its normal setting. So you're going to use a diaphragm to listen to bowel sounds because bowel sounds are high pitched and the diaphragm picks up high pitched frequencies. Hold it lightly against the skin and then start in the right lower quadrant and work your way up in a clockwise fashion. We start in the right lower quadrant because that's where the ileocecal valve is in the cecum, and we usually always would get bowel sounds there. So you want to listen to the frequency of the bowel sounds here, how they sound, gurgling, cascading. We'll have them anywhere from 5 to 30 is completely normal. That would be active bowel sounds. Hypoactive bowel sounds is not normal. They can be decreased following abdominal surgery or if they have inflammation in their colon. If they're hyperactive, you'll hear a loud, high-pitched signal. Very frequently, hearing them would be increased motility. Now, you ever had your stomach growl? So stomach growling is borborygmus. Borborygmus. It's the sound of hyperperistalsis. So that is kind of normal when we're hungry. So that really loud growling, that's what it is. A perfectly silent abdomen is very uncommon, so we cannot document absent bowel sounds until we have listened for 5 whole minutes in each quadrant before we decide that the bowel sounds are completely absent. Vascular sounds, we're listening for bruits. Okay, so we're going to use firmer pressure with our stethoscope, going to place it in all the areas of the vascular sounds, and we're going to listen for bruits. You may hear rubs too, so we're listening for this peritoneal friction rub, but mainly we're listening for hums and bruits over these arteries. So here is a diagram of where you'll find the listening positions for the arteries. We have the aorta with the renal artery on either side, the renal iliacs, and then the iliacs and the femoral arteries. So if we look here at a diagram of where our arteries are located, this is what we're listening to here. Okay, so aorta on either side of the aorta is the renal arteries, right next to the kidney. Then we have the iliac arteries where it branches off from that aorta. And then the femoral is going to be a little lower in the groin area. Percussion is next. We're listening for tympany here, tympany on the abdomen. We're going to lightly percuss in all four quadrants to listen for any variations in the sounds. If you have an enlarged organ, then you may have dullness. And then if you're tapping right over the spleen, you'll have dullness there. We're going to look on the back too after we're done we were going to do palpation first, and then we're going to do CVA tenderness. So with CVA tenderness, we are basically looking for kidney inflammation. You just tap a thump on the patient's back at the CVA angle over the 12th rib, and that will usually the patient will feel like a thud, but they should not have pain. Palpate the surface level and deep areas. So we're going to light palpation and deep palpation. Have them bend their knees so they don't be guarding their stomach and activating their muscles. We want their muscles nice and soft. Have them just breathe normally. Sometimes you might have to distract them if they're children or if they're ticklish. We're going to do um, light palpation, which is about 1 centimeter, and deep palpation is just a little bit deeper than that. We're looking for any like masses or abnormal feelings. It should just feel nice and soft underneath your fingers. So if you were looking for any enlarged organs or any masses that we would need to investigate, or any pain or tenderness. If you do discover a mass on your hand, you want to characterize it. So what does it feel like? Is it soft, firm, hard? Does it move? Does it not move? Does it feel smooth? Does it feel bumpy? And does it pulse? Is it tender? How big do you kind of think it is? These are some features that we can normally palpate. We can palpate the aorta and feel it pulsing. We can feel the liver's edge up here under the right lower quadrant, rib cage here. Sometimes you can feel the left sigmoid colon, with constipation or whatnot. Sometimes we can feel the colon areas, and then we definitely can palpate the bladder when it's full. Now we can palpate the liver by pressing underneath the 11th and 12th ribs and pushing on it. And now we're going to do the Murphy sign. We have the patient take a deep breath in while we're pushing up underneath their rib cage here. And when they have pain, when they breathe in, that's called positive Murphy sign. It's indicative of some inflammation in that area. The liver span scratch test you may see in your text, but it's not something we commonly do anymore. So it just is to detect another way of figuring out how large the liver is, but not that necessary to do in BSN. You can also palpate the spleen if you like, um, but it has to be enlarged 3 times more than normal to feel it. So not something we typically just go do and check on, but you would be able to feel it in the left upper quadrant. When spleen is enlarged, you're thinking of things like mono, leukemia, lymphomas, maybe HIV or portal hypertension, so liver hypertension. And then normally the spleen is not palpable, but so if you can feel a mass in the left upper quadrant, then we may want to suspect spleen enlargement. You can do palpation of the kidneys with a bimanual technique. And we don't typically go feel on kidneys very often, so I'm gonna skip. Some things that you would want to review would be rebound tenderness, which is Blumberg sign. So you press on the abdomen, and when you let go, the pain is worse. So they have worsened pain when you release the pressure of pressing, and that's indicative of a type of peritonitis. It can also be a ruptured appendix, which causes peritonitis. And when we do Murphy sign, we press in. They have pain on inspiration, and that would be a positive Murphy sign for appendicitis. I'm sorry, not appendicitis, but this would be a liver inflammation or gallbladder inflammation for Murphy's. For appendicitis, we have McBurney's point tenderness. McBurney's point is the right lower quadrant. The iliopsoas muscle test and the obturator test are two different tests we can do for appendicitis. And then there's the Alejandro score, the Mantral score, which evaluates right lower quadrant pain. Signs of appendicitis. So Blumberg sign, rebound tenderness. We have Rovsing sign. When you press on the left, they feel pain on the right side, so referred pain. Remember, your appendix is in the right lower quadrant here. They'll also have pain in this area when you pull their leg back, so that's hip extension. Hip extension. They'll have pain on the psoas sign. The obturator sign, you pull their knee up and have internal rotation of the hip, and they have pain on that side. So obturator sign. So these are all the signs of appendicitis that you'll want to take note of. When we're talking about children and looking at them, under age 4, they have a really, protuberant belly. They have that belly, the little baby belly, and that's pretty normal. They also have lumbar lordosis, which is normal until they, get over age 4 and they start getting more muscle tone and they're getting taller. Their liver is easily palpable below the right costal margin, and that's because their liver is bigger than they are, so they'll grow into their liver. We want to do atraumatic care when we're doing our assessment. So if they're guarding, facial grimacing, just looking at their age-appropriate reactions to our assessment. So a lot of school-age children and even into adolescents have really tiny abdomens and slimming. They get very slimming. They start to lose their pot belly completely normal. When they're an older adult, they will start to have increased deposits of fat on the abdomen and hips because it's redistributed away from the extremities. So tiny arms and legs and bigger bellies is what we're looking at here. With health promotion and teaching, we want to talk about hepatitis B and C screenings. It's recommended to be screened for hepatitis B and C between the ages of 18 and 79 by identifying risk factors, whether perinatal risk factors for contracting the diseases through that way, environmental, sex activities, and drug use. Check to see if they've had immunizations against hepatitis B, and if they have any diseases to refer them for treatment. Because hepatitis B and hepatitis C affect the liver, and that's why it's in the GI section. Another thing for assessment of an intestinal obstruction, mainly you're going to see vomiting and fever. They're not going to pass stool. They may have very hypo to absent bowel sounds in the late findings. And then it can progress to hypovolemic shock, so they can have third spacing and fluid shifting into the abdomen, and then it becomes distended. They're very ill, lots of vomiting, and we would be able to know from that. So they would have x-rays done to confirm diagnosis. We want to support the patient by making them NPO. Lots of times they're going to end up with an NG tube to help relieve the nausea. Common sites of referred abdominal pain. So the liver refers to the right upper quadrant. The esophagus pain, they're having esophageal pain. They may have pain behind the lower sternum, so it might feel like chest pain. Ulcers can present as chest pain as well and up into the shoulder. Gallbladder, they will have pain in the right upper quadrant. Appendix, the right lower quadrant. The pancreas will be mid-epigastric pain that radiates to the back. Kidney pain can radiate from the lower abdominal into the sides and back area. Small intestines can be just diffuse because small intestines basically covers all four quadrants. Abnormal findings you can see on inspection would be hernias, whether it's in the umbilical area, femoral area, inguinal area, incisional hernias from previous surgeries, diastasis recti, down, midline under the umbilicus. Abnormal bowel sounds, not really going to see a whole lot of abnormal bowel sounds except with hypo and hyper. There's a special one called cessation splash. You don't really have to remember this one right now, but it has to do with newborn period. You may want to listen for friction rubs and bruits and any sort of hums or abnormal sounds when you're listening to vascular. And any of your organs on the inside could be enlarged. So remember, inspection first, auscultate second, percuss and palpate. And you have completed your abdominal assessment.